Okay, Sawadee krap. Good afternoon, ladies and gentlemen. Thanks for Chairman, Mr. Chairman, to introductions, and uh, thanks for the committee to invite me to speak today. Okay, the topic today we talk about the resection margin in peripheral cholangiocarcinoma. I think this is the important issue that surgeons should know because of there's also a lot of prognostic factor for cholangiocarcinomas, positive margins, lymph node metastasis, perineal invasions. But I think this is one thing that the surgeon can give to the patients. So we must pay attention and considers about the resection margins. We know that surgical resection is the chance to cure in the patient with peripheral cholangiocarcinoma. And the goal of the surgical resection is achieve zero resections. This is the most important thing. And our data, and I think the data all over the world show that our zero resection is better than our one resections and better than our two resections. So the first thing we should consider before we plan the surgery is how can we achieve our zero resections? And how many types of resection margin we would consider? Dr. Wirit said in the morning, I will show you some case. This is the intra-aortic colon with highlight enrollment, right? When you consider to perform surgical resection, you must consider about the ductal margins, how many length from the tumor we can resect to achieve our zero resection, and you choose consider about the surrounding the tumors, margin of surround the tumors, how many length we can achieve our zero resections. So the resection margin in peripheral cholangiocarcinoma, we easily divide into two groups, radial margins and ductal margins. Radial margin includes periductal soft tissue, parenchymal, parenchymal margins and vascular margins. And the ductal margins, it includes proximal margin, it's inside the liver when you perform parenchymal resections, and the distal margin in common bile duct, okay? This is the two types of resection margin we choose consider before we perform curative resections. And this question is this comparable to the survival outcome between radial margin and ductal margin? I think this is the largest and comprehensive study about the radial margins from Professor Ibata, Nagoya. They, they collect the data of our one resection patients and divide into radial margin group and ductal margin group. They found that the most important factor, important margin that affects our one resection is radial margins. It's about 60 to 70% of the patient in our one resection is radial margin positive. And they found that the survival outcome is not different between radial margin and ductal margins. As same as our data, we collect our data and analyze and show that for the patient with ductal margin and radial margin is not different in survival outcome. So when you concern to perform curative resection in peripheral cholangiocarcinoma, not ductal margin you concern, but also radial margins, okay? And the next question is, how can we achieve our zero resection when we perform curative resections? For radial margins, Dr. Wirit said in the morning, according to my knowledge, there's no paper or literature that talk about the parenchymal margin in peripheral cholangiocarcinoma. Therefore, we use the intra-aortic cholangiocarcinoma data to assume that if you perform liver resection in peripheral cholangiocarcinoma, 1 centimeter from the tumor is adequate for surgery. It's as quarantine that you can achieve zero resections. And for periductal and vascular margins, you must peeling the soft tissue from the vascular to achieve vascular resection. And if there is vascular invasions, vascular invasion, vascular resection and reconstruction is necessary to achieve vascular resection, just like Dr. Atwood said. Okay. And for ductal margins, the question is how large we can resect the bile duct to guarantee that we achieve R0 resection. I think this is the landmark paper from Professor Ibata. Tell us about the length of the resection margin to achieve R0 resections. He collected data and found that 1 centimeter can quarantine avoid R's invasive carcinoma and 2 centimeters to avoid carcinoma in situ and high-grade dysplasias. So we have two magic numbers, 1 centimeter and 2 centimeters. The question is, high-grade dysplasia and carcinoma in situ, is this equal to R1 resections or it's comparable to R0 resections? This is the question because of 2 centimeters is really range. It's so long when you perform perihalal resections. I think it's sometimes we cannot achieve 2 centimeters in perihalal cholangiocarcinoma. So carcinoma in situ and high-grade dysplasia, it's affect the survival or not. This is the debatable issue nowadays. There's a lot of literature talk about these issues. I will show you some papers. This from Korea. They collect the data of the patient with extrahepatic bile cholangiocarcinoma. Majority of patients is perihalal cholangiocarcinoma, and they compare the R0 resection, low grade, high grade. And they found that high grade dysplasia is lower survival outcome than R0 resection. However, this paper from China this year, they compare R0 resection and Berlin, this is dysplasia and the precursors of cholangiocarcinoma, as we know. And they found that there's no difference survival outcome between R0 and high-grade dysplasia, Berlin. And they analyze subgroup analysis for about the distal margins, proximal margin, low grade, high grade, something like that. Especially, they conduct a subgroup analysis for lymph node metastasis and negative. And they also found that there's no difference between Berlin and R0 resection. However, for Japan, they analyzed the subgroup analysis in node negative patients. And they found that in overall cohort, there's no difference between R0s and high-grade dysplasia and CIS. However, when we look at the node negative patients, it's difference between survival outcome between high-grade and R0. SMS, this is a paper from Nagoya. They conduct the research about the carcinoma in situ in early stage cancer. Early stage, it means that node negative and TS to T2. And they found that they have some benefit. There is improved survival outcome when you additional resection CIS. And if the patient have CIS or high-grade dysplasia, the patient have a lower survival outcome than R0 resections. So CIS and high-grade dysplasia is not different in the overall perihalal cholangiocarcinoma, but in early stage cancer, especially in lymph node negative TS to T2, it is important. And how about the advanced stage cancer? The next topic is I think it's talk about nowadays is that in lymph node metastasis patients, resection margin is matter. Because of our series that I show you multi-variable analysis, we found that resection margin and node positive is the independent prognostic factor for the patient with perihalal cholangiocarcinoma. But which one is the most important? This is your R0, R1, R2, and this is not negative and positive. There's a lot of paper nowadays to show this data. This is from Netherlands. They include the patient from European cholangiocarcinoma registry and analyze. And they found that for the patient with lymph node negative, there's a R0 and R1, it's a difference in survival outcome. However, in the patient with node positive, R0 and R1 is not difference. As same as the paper from Japan. They collect the data and analyze lymph node negative, lymph node positive, and resection margins data. And they found that node negative patient is difference between R0 and R1, but in node positive patient, it's difference, but not statistical significance. Okay, just SMS our data. Dr. Rich showed you in the morning that's different, but when we include R2 resection, just only R1 and R2, it means that just only curative intense surgery, and we compare the data, we found that R0 in node negative patient is the same. It's benefit for R0, but in node positive patients, it's not different. I think this is the most important topics because of sometimes node positive patient, there's a role of neoadjuvant treatment in this patient, but adjuvant treatment is not effective nowadays. So when you perform the curative resection in the patient with grossly positive lymph node in peripheral curvature, you must consider about this result, okay? Therefore, for achieve R0 resections, in all of the patient with peripheral carcinoma, 1 centimeter is okay because you can avoid positive invasive carcinoma. But in early stage cancers, you must consider about carcinoma in situ and high-grade dysplasia for 2 centimeters. But 2 centimeters is very long, right? Therefore, there is some method to facilitate us to justly resection and evaluate the margins. So the question about the first sections. The first section is benefit in the patient with peripheral cholangiocarcinoma. And the most important question is that when we perform resections, is positive margin, it's impact the survival outcome of the patient. This is the most important question. There's just a lot of paper nowadays to discuss about this topic, and there's a lot of heterogeneities of the result. Some people say that it's benefit, some people say that it's not benefit. I will show you the paper. This paper from Japan. They conduct the research for R0 resection and after resection, secondary R0 and final R1. And they found that there's no difference between secondary R0 and R1 and different with survival outcome compared to R0 in the first initially. And this is the paper from Netherlands. They show that this is the algorithm, and they found that there's no difference between secondary R0 and R1 in final. And R0 resection initial is the better outcome, okay? However, this is the paper from United States. They collect the data of the patient, 250, and this is the patient in any arms. And they found that there's some benefit when you additional resection because of secondary R0, it's comparable outcome to primary R0. You see that there's a lot of heterogeneities of the result. When we look at the minority of the patients from this is the paper from Nagoya that I show you. Carcinoma in situ and high-grade dysplasia, when they additional resection and secondary R0, and they found that it's benefit when carcinoma in situ and do additional resection. The result is good, comparable with R0 resection. And this is the meta-analysis. They conclude that they found that there's a heterogeneities of results. So they conclude that additional resection should be recommended in selected patient. But what is that patient? When we look at the whole data nowadays, this is the code that we recognize. I think biology is king. Selection is queen, and the surgeons, it's just like a princess in principle. Therefore, because of, I think there's a lot of the tumor biology of the patient. Any patient have a different tumor biology. Therefore, we must select the patient case by case to perform resection and to perform additional resections. So some paper indicate this, it told us about this. We said that positive resection margin in first section, sometimes it's indicate that the patient has aggressive tumor biology and has systemic disease. Therefore, it overshow the potential benefit of achieve R0 resection. So I think For frozen sections, it's a, sorry. Oops, okay. I think it's benefit and it's reasonable to perform if you can perform frozen section because of it can guide you to perform further selection, further surgery. However, you must select case by case. And if the frozen section result are positive carcinoma SI2, I still recommend you to further resection because of sometimes we have effective adjuvant treatment in the future. That Professor Ibata will tell us about the adjuvant treatment. If possible, you must resection additional. But in the case with poor prognosis factors, for example, lymph node metastasis, high tumor marker, I think you must select case by case because of if you perform re-resection, we can encounter with difficult anastomosis with bilioenteric anastomosis, okay? But the result positive high-grade dysplasia or carcinoma SI2, I encourage you to re-resection in early case of cholangiocarcinoma, okay? So I will show you some video to perform adequate resection to curative intent, okay? This is the patient have the tumor in the hilar region, just intraductal growth type, okay? This is a tumor here, the left hepatic portal vein, middle hepatic vein. When you perform left hepatectomy, it's difficult that Ajahn Polisit told us in the morning, but extended hepatectomy is okay. You can achieve arterial resection and not risky to radial margins. But left trisectionectomy, I think it's too much. So in this case, we perform extended resection the segment 5 and segment S sometimes. However, when you perform resection middle hepatic vein, segment 8 and segment 5 will congest, right? Nowadays, we perform just like this, resection the segment 5 and middle here, and preserve the middle hepatic vein here. Okay, we show you the tumor. We will resect the hilar regions to achieve arterial resection and parenchymal transections. This is just like video you saw in the morning. We dissect the lymph node group 8 to explore the common hepatic artery here. And dissect the neurolymphatic bundle in the hepatoduodenal ligament. This is the vascular structure that we follow and dissect the neurovascular bundle here. And encircle the common hepatic artery, GDAs, and hepatic artery proper here. And slowly dissections and encircle this common hepatic artery and dissect, use a cautery. I usually use a cautery to dissect around the hepatoduodenal ligament. And this is left hepatic artery, right hepatic artery, and encircle the right hepatic artery in the right side to ensure that there's no tumor invasion. And after that, resect along the left portal vein here, expose the left portal vein and main portal vein, and lymph node group 12A, 12H, and encircle the main portal vein. You must clear, I usually clear the neurovascular bundle from the vascular structures, especially in artery, just like this. And we ligate the bile duct, and I usually shoot hanging the bile duct here to evaluate the distal bile duct. We cut the bile duct here and evaluate the distal margin here and additional resections. Unfortunately, in my centers, cannot send to the first section because of technically and personnel inadequate, something like that. But I encourage you, if you possible, to send the first sections, like the portal vein and hepatic artery, and dissect around the hepatoduodenal ligament to clean this just like this. And after that, we mobilization of the livers and perform parenchymal transections. That I told you, intraoperative ultrasound is mandatory when you perform liver resections to guide us to achieve arterial resection. This is middle hepatic vein. I will see right. We follow the middle hepatic vein here And we found the tumor inside the duct here. This is right portal vein tumor and middle hepatic vein. Okay. This is the lines of left hepatic artery, difficult, and sometimes it's a R1 resection here. So we perform external right here, resect the segment 5, and preserve the middle hepatic vein here. Okay, we mark the landmark and preserve middle hepatic vein here, and perform parenchymal transections. It's depend on your family. I think CUSA, Sonastar, touch cams, sonization, harmonic, or just only electrocauteries, just like I've usually perform. It depends on your family, I think. Okay. We like it as V5, and we like it as another V5, and we found the right anterior viaduct here, right anterior viaduct, and we will turn around here to preserve the middle hepatic vein here. Okay, we find the middle hepatic vein here. Yes, that's right. And we encircle, ligate, and preserve it in the segment 8 to decrease the congestion of the liver. And continue to parenchymal transections. Some surgeon will complete parenchymal transections and transect the bile duct. But in my preference, I just only transect the parenchymal to here and cut the bile duct before complete parenchymal transection. And left hepatectomy is difficult, I think, because of there's a lot of variation of the hepatic artery and portal vein here. You must concerned about the variation of hepatic artery, supraportal tie, infraportal tie, or combat tie, something like that. Okay, this is supraportal tie of right posterior hepatic artery, and this is right posterior intrahepatic duct. This is supraportal type. Okay, this is bile duct and complete parenchymal transections. So, in my conclusions, resection margin is more important for us as a surgeons, because of it's just only the one thing we can give to our patients. Resection margin divided into radial margin, ductal margins. Okay, parenchymal margin 1 centimeter, 1 centimeter is okay to achieve arterial resection. For periductal vascular resection, you will peel the soft tissue to the vascular, and if there any vascular invasion, resection and reconstruction is mandatory. And for ductal margins, you must concern about our invasive carcinoma in any case, but in early case, carcinoma in situ and high-grade dysplasia is important. And you must concern about the early case or poor prognostic factor. And I think that lymph node metastasis patient, sometime, I think in the future, pre-operative or neoadjuvant treatment maybe take a role in this case. Okay, thank you for your attention.